Hello and happy Friday. Welcome to Two Therapists, or should I say Three Therapists, Sitting in a Tree, TALKING. Here we are again, back at Bellworks Studio. My name is Harla Rudolph. I'm the owner of the Speech Tree, and
I'm Carolyn Herbin, the owner of Ready, Set, Grow.
And we are so excited to have a longtime friend and colleague, feeding therapist to the stars, I call her, Jacki Kemp, speech language pathologist. She has worked at the Speech Tree since, what did we say, Jack? 2015. An incredible, not only an incredible speech pathologist, feeding therapist, but an incredible human. And we have so much to talk about today, in regards to feeding therapy. So welcome, Jacki.
Thank you for having me.
Is this your first podcast?
This is.
We're going to have fun today.
Thank you.
So tell me a little bit about yourself, about your background, where you went to school, and your training. I'd love to hear it all.
Sure. So I graduated with my master's in 1997.
Me too.
Yep. And I began my career actually with adults. So feeding and swallowing has been a part of my career forever. I moved down to this area about 10 years ago, and then we met soon after that. I was here 2014 when we met soon after that. And the last 15 years, I've been doing pediatrics. Kind of moved into the medical field with hospital and pediatrics, and then outpatient pediatrics, and it slowly moved that way.
So you worked in hospitals in New Jersey? Mm-hmm. Which hospitals?
Morristown Hospital and Chilton Hospital.
I remember you once telling me you were on the cleft palate. Was it
cleft palate team at Morristown Hospital? Mm-hmm.
You must have seen
so neuroscience, neurosurgeons and developmental pediatricians and what kind of doctors deal with the helmets? Cranio doctors. I can't remember all the names of all the specialties, but you'd walk in and there'd be a table of 20 doctors and then one family. Mm-hmm. But very educational. It really helped me move more into the medical field even more. Medical piece of speech therapy.
You must have seen a lot there. All the medical anomalies.
Amazing.
Yeah.
And you don't forget it. Mm-hmm. I actually recently referred some of my families from here up to Morristown because you don't forget that the team was just such a nice environment.
Mm-hmm. So I have a question because this comes up all the time from some of the students that I work with, and they ask, how do you become a feeding specialist? Like, what's the certification or the licensure? Right. And there really isn't. So tell me kind of...
I get that question too. That's definitely more of a very recent thing, being able to take courses and then have these certifications. It's just experience, hands-on, being able to be part of teams where you're growing. And then you take your expertise and you add it to real-life experiences to help families. Mm-hmm. And then whether it's adults or pediatrics, I feel like that's been the turn. It doesn't matter adults or pediatrics, but it's the turn of having to help the families. Mm-hmm. That's really how you grow. You have to be in those real-life, on... the real-life experiences on the moment is what I wanted to say.
So what is feeding therapy? Because we know what it is, but for all the parents and families and everybody listening, let's explain what it is.
Sure. So for me, feeding therapy begins with trying to find the most safe approach to make sure that child is functioning appropriately and being safe in all environments, from school to home, with families, with their grandparents. So safety first.
In managing foods? Or
Managing foods, but just being able to be part of their everyday. But then, on top of that, I really try to look at the whole package. So are they feeding themselves? Are they sitting safely? What kind of foods are they eating? Are they being exposed to the right types of foods? And how much awareness do the parents have? And educating the parents. So again, it's about safety and about food, but it becomes the whole package. And that's, when I sit with my families, I explain that there's multiple roads that we're going to be, going down, not just about, I need my child to eat more than 5 foods.
Right, right.
So that's really therapy for me.
So I think what Carolyn and I mostly see, as a speech pathologist, and when clients come in, and also as an occupational therapist, we both work with feeding. Some of the parent concerns that we hear would be, my child only eats 3 foods.
My child only eats crunchy foods. My child only eats soft foods.
Right.
Yeah.
Yeah.
What are some of the parent concerns that you hear at the speech tree?
So those are definitely my older kids. I'll say like 2.5 or even 3 and up are the amount of food. They only eat very little. They eat, like a bird.
The picky eaters.
So it'll be how much they're eating, the types of textures, or they'll only eat certain brand foods. Like they'll only eat it when it's a bag of this type of pretzel.
Right.
So those are more of the behavioral approach to the therapy. And then even what I was speaking about before was more the medical approach. So, going into these evaluations, I got to figure out what road we're taking. Is this more of a medical approach?
Right.
Where they're coming with any kind of medical backgrounds, constipation, GI issues, reflux. Those are all those medical pieces. Or just even like, that they were born with failure to thrive or cerebral palsy or any of those kinds of
Explain what
medicals.
failure to thrive is.
Where they're born and they're not gaining weight and they're not responsive, they're not sleeping well. All of their day-to-day routine is not moving forward, but the biggest piece is that they're not gaining weight. Right. And some start with that, then they get better, but then they kind of actually level off, and then they're going backwards again as they're getting older. So that failure to thrive is not just day 1 at birth. I'm seeing a little one now at 2, still considered failure to thrive. So, so that's the medical piece, and then there's the whole behavioral piece, which is definitely what I'm hearing from you guys.
Right.
Well,
And I know there is that behavioral piece, and as an OT, we'll typically refer, and this is kind of what I want to ask you about your evaluation process, because if a parent comes in and tells me, my kid only eats soft foods, my kid only eats, yogurt or something, I'm assuming you would look at then the inside of the mouth and the way that they're eating and the way that their mouth moves and their muscles. So we'll refer them to Jacki or another speech therapist, just to rule out, that it's not just sensory and that there isn't more of a mechanical issue. So I guess my question is, when it becomes to the evaluation process, what are you looking at as far as how a child eats?
Sure. So I actually speak with the parents before they even come to my session, and I ask them to bring like a mini meal of everything that they're actually currently eating. So it's a successful, positive first session.
Love it.
I didn't want to start with everything that they're not doing, and then they sit and then I don't see
You don't
anything.
see
So
anything.
I want to see the highly motivating, foods and situation that's working for them at home with the cups that they're using and the spoons and the forks, so that I can watch from the minute that they pick it up, either with their fingers or their fork, how they're doing that, where it's going in their mouth. And I'm looking if they're, what kind of pattern they have. Are they chewing? Are they munching? Are they pocketing their foods? What way is their tongue moving? How many teeth they have? I mean, the list is infinite. So it's all in my head.
Right.
But I'm looking at, as I said, that whole package. So it's not just about what foods are in front of them. It's also, how is it being presented? Are the parents giving them a whole sandwich? Or are they walking in and all of a sudden that sandwich is in little pieces? So it's all
Explain
of those
why that
words.
makes a difference. We know why that makes a difference. But
Yes,
explain why
true,
that makes a difference.
true. So, but that's why I asked
Yeah.
the families to bring it in the way that they're doing it at home, because all of a sudden, they have this huge sandwich in front of them. They're a picky eater. But then I take away the sandwich and I put one piece in front of them, and then they start eating. So I like to see how the parents, present it, how they approach it, and then I kind of tweak the situation. Or, that spoon's not working, so I might switch up the spoon. And then all of a sudden say, put the spoon on this side of their mouth instead of in the middle of their mouth. So my assessment also becomes somewhat of a therapy session, because I'm trying to see
Different things.
What
if I
works.
can change something, will they respond better? And have the parents watching that. So it's just as much of an assessment as how can I begin that therapy session and give strategies as they walk out the door as well.
Love it. Love it. I actually want to comment on what we were saying about behavioral because this often comes up a lot.
Yes.
And I'll even hear this sometimes from other speech therapists in the fields who are maybe doing feeding and, they're like, it's behavioral, it's behavioral. So what I always say, it never starts behavioral. There's maybe 0.99% of kids where it starts behavior. No child says, I'm going to
give you a hard
I want to
time.
give you a hard time. Kids want to succeed. Right. So, of course, we know it can become behavioral, but what are some of the origins where it typically starts where you'll see a feeding delay occur?
Reflux.
That's a biggie.
That's my big
'cause
one.
It's painful then for them to eat.
Yes.
And they become,
So babies, but not even just the babies, even the older kids will come in and the parents are like, they're barely eating, or they only will eat during the day and by the end of the night they won't touch a thing. So as I was bringing up before, I go all the way back to the medical stuff and I'll ask every little question about sleeping, how much are they drinking, what are they drinking, do they have food allergies, do they have a history, so now they're 2 or 3 years old, but did they have a history of reflux? Oh yeah, they were on medication. What medications were they on or have they been on? Again, another infinite list of a million different things that are their start to life that could still be influencing the next phase.
So it could be a variety of reasons what you're saying.
Yeah.
So not only did they have reflux early on and they have had this learned behavior now that
Yes.
food is painful, but also could still be experiencing the reflux and parents don't even know it.
Silent reflux is a big one.
and kids don't know how to express
No,
reflux if
No.
they
They just don't want, they
Yeah.
don't eat. Or the behavioral piece is either refusal or there's often like body movements. So we'll see like arching back or we'll see a head turn. Or just even crying and screaming. So that's the behavior. The parents are bringing them in saying, this is all day long. So we look at the type of food. Maybe some of the foods are too spicy. Maybe they're mixing foods and we need to make them more bland and separate food. So, and also then maybe not overfeeding. Sometimes kids are getting too much food. So let's do small portions all day long. The biggest thing that I've been doing to all my families is helping them work through changing their day-to-day routine. So, kids are eating 3 times a day, maybe have a little bit of snack, they're drinking a ton all day. So we kind of like put that behind us and work on it's hard with school-age kids, but, trying to feed kids every 2 hours, small amounts, drinking along with meals and not waiting to have like 6 or 8 ounces like once in a day or milk or water or anything, but organizing the home environment just as much as the type of foods, where they're eating, the type of chair they're sitting in and all of or even utensils, all of these little pieces of the puzzle. I try to organize that out better for them just to make it that much easier. And then all meals, the 3 meals a day, the big ones, are preferred foods, right? So meal times, I'm so stressed out. They're
It's
not
already
eating
stressful,
for me.
right?
I sit down. They say no to everything that's in front of them.
Right, and
so,
you make this food and you end up throwing it away.
Or like 10 different things.
Yeah.
Yes. So it's, let's find only preferred foods, and then we want to build up on all the new foods at the, non-hunger times of the day.
Right.
When they might be interested, but we only need them to start trying it, not
Say that
eating the
again.
whole thing.
Say it again, what you just said. I think
Okay.
this is so key about the preferred foods during the meals. And
Yep.
go ahead.
Okay. So, so we come up with a list, even if it's 3 or 4 food items. It doesn't even matter what they are, but to start with me, those 3 times a day, I want them to be positive for the families. So breakfast, lunch, and dinner need to be foods that they want to eat. Even if
it's the same thing.
Even if it's a protein bar, even if it's a granola bar, even if it's, cereal. Right now, to start our sessions, let's get in a good routine of eating things that they enjoy so that meals are
Positive, making it positive. Yes.
And then as we build our sessions and work on new foods or changes in what we're doing, we're going to start those at more of the snack times or weekends. But we have to find the right times because my child's tired or, they don't get home till 4 o'clock. So I have to work with people's schedules and get creative, but show that it can work. And we were talking about that we're working 7 days a week. I get texts and from family members saying, well, what should I do now? And it's a Sunday at 3 o'clock. But I'm happy to do that. I want to help them on the moment because on the moment and helping our families is way more important than waiting the week and saying, I wish I helped you a week ago.
So I said you're a good human. I mean, none of us going to do that on a Sunday. And you care.
How important would you say? I'm thinking it's important, and I'll tell you, I'm a picky eater, so I probably could have used.
I never knew that.
So as a first-time mom, my first child, Matthew, is very picky. And he's gotten better. But I think a lot of it was due to lack of exposure. So how important do you think exposure is as a baby? Because I would only give him what I liked. I'd hate eggs. Yeah. I can't stand the smell, so I won't cook them in my house. So he never had them. And now he still won't eat them. And so I'm like, it's all my fault because, I never exposed him to the things that I don't like. So I guess as a baby, how much should parents be exposed? Not even a baby, when they start eating table food, obviously. How much should parents be exposing them to new foods throughout the week?
Sure. Well, so that was kind of a loaded question for me. So to be honest with you, I feel strongly, bridging off of what you said, it really has to go off of what you guys do at home first. I can't say to a family, you have to go feed your child eggs, or so I have vegetarian families. Yeah. They have to try chicken. So it can't come from me, Jacki Kemp, what I think is important. I say to them, what do you want in your home? What works for you? What kind of meals are you making first? That's how we get started first, and I build from there. Babies, it might be a little bit different, especially like 9-month-olds where they're not eating much of anything. I will I literally send my little to-do list and say, these are the first 3 that we're working on, but here's a list of 15 that we want to get to, right? But I'm not that type of therapist that says, your kid has to eat a million different things. I feel more strongly that it needs to be off of what works for your family. Do I want every child to have exposure to everything? But that wouldn't be fair. Right.
You know what? Explain what exposure is, because I think that that's a general term. Exposure doesn't necessarily mean you're, putting it in their mouths. Like, what is exposure? Could be.
So initially, exposure will be through me, right? So you're bringing new foods. It's always going to be a few preferred foods, and then it's going to be 1 or 2, maybe a few more, but 1 or 2 new foods, and we expose them to them. And I follow kind of a strategy behind that, which we can talk about.
You mean like visually? You're putting it on their plate?
Visually.
And this is what the parent is doing at home as well?
Not yet. So it'll first start with me. Sometimes it needs to be in my session. It might be 3 of my sessions first, and then exposure or using the word exposure would be, I'm just trying to overuse it, would then be at home, but only during snack times, right? Only in those times that are non-threatening and not a big deal, because those new foods and those exposure to new foods are the most stressful times for these children, right? So the last thing I want to do is say, oh, well, every meal it's got to be out just sitting there. Or, and again, other therapists and other practices may have a different approach. This is what's working for my families and my approach. That I don't try to bombard and overly make it that it's all about food, because it's a stressor. So I want it to become a positive experience in the right way and not overwhelming and overbearing. So what I do is I do it 3 days in a row. So I have this whole approach of 3 days on, 2 days off. So 3 days, you're going to work on that new food, exposure to that new food at your snack time. But then 2 to 3 days, you're going to take a break from that. And that food is not part of the day. And we either might move to another new food that we've spoken about, or there's a break from that and snacks are just your normal foods.
Now, what would that look like? Would it be just putting it out and letting the child touch it if they want to try it, or
It'll be part
just-
of it. It'll be part of other foods on the plate too. So let's say a snack time is pretzels and grapes.
Okay.
And the new food that we're working on is maybe even a different pretzel. Let's keep that. It's the same. It's the same kind of food group. So there'll be only one or two of the new pretzel, and maybe 3 or 4 of the preferred pretzel, and then the few grapes. And then they're just there. And I actually ask parents not even to talk about it, just that it's there. But it's also age dependent. So, my younger ones, it's going to be a very different approach than my 9 or 10-year-olds. And the 9 or 10-year-olds are going to have a much more involved piece of this puzzle. And they're going to have to take some more ownership on what they're working on with me.
Such as?
We keep logs. I have like a communication book, and we keep logs of what they're working on. A big thing I've been doing with a few of my families, from my 5 and 6-year-olds and up, is meal planning dinners. Knowing what, on a Sunday night, what they're having on Thursday. And it's either that they pick from 2 things, so that mom at least knows that those are the last 2 choices, or on a Sunday, they're picking for the whole week. And there's no discussion. It was like, that's what we picked. And then, and it's really alleviating a lot of families' anxiety of, it's 4 o'clock, what are we doing in an hour and a half from now? So the communication book has been a huge one. Also, having my older ones have positive energies at meals. So I work a lot on talking positively about foods. How does it smell? What does it look like? What does it feel like? Instead of hearing yucky, I don't like that. That's all that, negative energy, and just everything stops right with that. If we start using, descriptive words and positive energy words, how does it smell? What does it look like, in good ways? And I give a lot of good examples with them. It is so interesting to watch the turn of these kids starting to realize, wow, I guess I can look at it from a positive way. And then also having the parents see that as well, because it's really the parents, feeling so stressed about it at these meal times. The kids, like us, are stressed
Yep.
because they're saying no to everything.
Right.
But it's
Well, and I think when then the parents have anxiety, the kids see it, right? And then they feel it.
It's a vicious
And it's
And
like,
it's-
why are they anxious about it? Is it going to be bad? Is it going to be something I don't like?
It becomes a power struggle and
Yeah.
control, and then it becomes worse and worse. So I love that you said putting positive and concrete words to it. So what happens usually during mealtime, the child will say, "This is yucky." The parent says, "No, it's not," and then it's back and forth. But if we're saying it's red, it's crunchy,
Right.
you can't argue with that,
Right.
right? It's red and it's crunchy.
Right.
Or we don't ask yes or no questions, like, do you want that?
Right.
Do you like that,
Right.
right?
that's why, which one do you want?
Right.
Right.
Control
And-
for the child.
Right, and you start that from the beginning.
Yep.
Here's your 2 choices from tonight. Do you want the macaroni and cheese or the chicken finger? So these are 2 preferred things that you do like.
Right.
Which one do you want? So that it's not, mom just made macaroni and cheese and now you've said no because you picked it from before.
Right.
And
where are you going to go from that? Like, do you want it?
Yeah.
No.
No.
Okay. It's
Right.
like,
Yeah.
absolutely.
I like the 2 choices.
No,
Yeah.
and kids like being involved, because I know sometimes like we'll have kids who can't tolerate like textures or things, and we'll have parents help have them, oh, why don't you guys make something together, have them pick something to make, and if they're stirring it rather than touching it or rather than eating it, it helps them to gain the exposure that way and to want to be involved. Kids like to be in the kitchen, using mom and dad's bowls and spoons. And,
Can we talk about the sensory piece? Thanks for
Yeah.
bringing that up. So, Jackie, I know medical is where you come from, and you know that medical piece, but you certainly only know the sensory piece as well. So, kids that have feeding delays and disorders, one of them etiology being medical, another etiology origin being sensory. So we see
Yeah.
a lot of that. Tell us about kids.
So I was actually going to follow up on what you were talking about with the cooking and all of that. What I'm realizing in a lot of my sessions is you do your evaluation. You don't even know some of them have sensory issues in the evaluation. because they're eating their preferred foods.
Yes.
Right? And the parents don't really look at it that way. It's just that it's a power struggle or that everything about eating is negative, but they haven't pinpointed that, oh, they don't like how it smells. They might just say, they'll make a comment, oh, I don't like that. Or, ooh, that smells yucky, but they're not making the connection to it becoming more of a sensory concern. So I'll be working on my steps. Let's touch first, then let's smell, kind of working up our sensory steps to getting to eating. So let's say they don't want to touch it. I'm learning over my years, it's been a learning curve for me that am I going to get stuck on working on touch? Let's use a fork. Yes, do I want to work on it? But I also, so then I might do that as a separate session, and we only do sensory play and not worry about eating. But I might not have picked up on that right away. But then I'm like, wait, I'm spending all this time, and they won't even put their finger on it. So I'm like, I want to get past that. I need to hold on to that information, know that it's a concern. But from a feeding perspective, let's use a fork.
Jackie, do you know how many times we have families come, and I'm not downplaying, any other feeding places or specialists. I know everyone has their approach. But one of the things that we're hearing is, we've been feeding for a year, and we've worked on touching a tortilla for a year. True. And, no,
that was
that's
even
not okay.
years ago, too.
Yeah.
I mean, I remember many of those stories years ago. Now it's kind of turning more medical things that parents are coming to us for. But yes, I mean, that was a big thing. Why am I getting stuck on that? We don't need to touch everything we eat. We don't even do all of that, right? And then smell. I mean, how many times do you walk into a restaurant? I've done this with my husband before. He'll be laughing. But where you walk in a restaurant and we walk out because we didn't like how it smelled.
Yep.
Yeah. Well, that's me with the eggs. I'm
Right.
telling you, I can't smell eggs. I can't be in a room with eggs.
No, I know.
So, again, how do I compartmentalize that in my session?
Right.
I pocket it, here and say, all right, and I'll deal with it later. Let's move on. All right,
Yeah.
I can tell that smell is an issue. But at the same time, it also helps desensitize our kids.
Right.
So you don't want to completely put it away. I just need to do it separately from the eating.
Right.
And I'm actually working with a child right now where smells and sensory stuff is a big concern. So, I'm getting kind of creative, and I'm going to work on some of the sensory through toothbrushing. So it's separate from eating. So I can work on it and help desensitize his mouth. And then I was thinking about how am I going to even go about the smell piece. Not with eating, though. I'm not going to do foods. I'm going to do something separate.
And I think doing it separate, like you said, and slow, because our sensory systems can become so overwhelmed when there's so much going on. And kids with sensory issues, most of the time, don't just have an aversion to smell. It's aversion to smell, touch, sound. And so when they're stuck in a position and somebody's telling them, eat this, touch this, put this in your mouth.
Oh, my God.
It's fight or flight, and they melt down and shut down. So I think
I'm trying to
doing
find
it, breaking
successes
it
in a different way.
down, and doing it outside of feeding, and then bringing it back slowly is key.
So a lot of feedback I get from parents is that lunchrooms are a sensory nightmare. It's loud. It smells, right? I mean, we get that a lot. It's a nightmare for kids.
Yeah.
Yeah.
So
I
on that separately,
those are really hard situations for a lot of the kids. And actually, a few of my clients right now, I get the parents to bring in the menu, and we pick once a week where the children pick one thing that they're interested in trying for multiple reasons. One, for flexibility. Two, for being part of the community. Whether it smells or, just anxiety with eating, whatever the reasons behind it, but then it helps them bridge that gap to, oh, well, look, my friends are doing it.
Right.
So I actually do that. I've done that with camp menus as well over the years. But right now I actually have 2 kids that bring in their monthly menu when we look at the 4 weeks at a clip. And
Love it.
the child gets to pick one meal a week. And I'm getting really nice feedback from that because, again, I'm bridging what we're doing in the office to their real life.
And kids are so
home
much more
experience.
likely to eat something if their friends are eating.
Yes.
If
But the parents are nervous to do that because they're like,
they
well,
think
but
they're going to starve if
they're
they
not
don't
going to
eat.
eat. So I always say, send your lunchbox, but still let them buy the meal. And then they can do both.
Love it. So we have the medical, the sensory, and And then in comes the motoric, right? We didn't talk about motoric yet. No, the motoric piece. Okay. We do see a lot of kids that may have low oral motor, low tone, difficulty managing foods. So when you were saying a child may come to you, and a family says they can't eat the food, we need to send it to a speech pathologist, because the speech pathologist is the one that's really going to be looking at the mouth and the oral motor skills and how they manage the food. So what are you looking at when you're looking at how a child manages foods? And I know it's different at each age. Of course, a 6-month-old is going to be different than a 6-year-old.
Right.
But we have to look at that motoric piece.
Sure.
So-
Actually, it's going to involve a bunch of different things. It's also going to involve, bridging off of what you said, breathing, coordination, suck, swallow breathing. So I even watch that pattern. How are they, are they able to suck from a straw? Are they only doing it once and they're done? Are they able to coordinate, suck, swallow, breathe more than one? Whether they're all the way, my little 4-month-olds that I've seen somehow, the little ones that I'm watching do all of those things, and all the way up to all different age groups with all different types of disabilities, to make sure that we even have coordination from here. And
Show
then,
what here is, because it's podcast.
Here, sorry.
Your chest, your breathing, your lungs.
Yeah, so breathe. Yeah, so being able to coordinate those muscles, which are basically involuntary muscles, but when they're not functioning correctly or appropriately, we have to break it down. So making sure that the cups that they're using, the utensils that they're using, the bite size or the amount that they're taking in, can they handle all of that? And it starts with just the breathing. If they have too much in their mouth, then they're, not taking that breath and they're not swallowing correctly, and all of a sudden they're probably pocketing. And then it goes into more of the motoric. What is their muscle control? This is your muscles as well, but your muscle control from here. So is your tongue moving in the right manner? Do you have anything restricting your lips or your tongue?
Gotta get into that.
Right, we'll move to that as well. What about even teeth? I have little ones that come in tons of cavities, or they're missing teeth. So there's so many different pieces of the puzzle to find that. Let's go back to what feeding therapy is. The safest way for our kids to eat, right? So, and that's what I'm looking at. I look at all of the different things that we've spoken about to make sure that the plan of attack is going to get them to that end result of being safe at home, at school, with grandma, with grandpa, the whole package.
It's a lot. It's
Yeah,
a lot
it's
in
a
an
lot.
evaluation.
Yeah,
And
yeah.
that's why it's so important that you find a professional that knows what they're doing.
Yes.
So I feel like we get our licensure as speech pathologists, as occupational therapists, but a specialty like this is really someone that really needs to know what they're doing.
Right.
And it's frightening because you are working sometimes with medical babies. And to make sure, if I could say anything to parents, it would be to do your research and make sure you're going to someone that knows what they're doing, has experience. You've spoken to another parent that has gone there. We've heard nightmare stories, and one of the things that we're hearing, Jackie, you hear it day in and day out, is about tongue ties and the trend with this now. And tell me what's happening and what you're seeing,
Okay.
and how that relates to feeding. And
Yeah, absolutely. So I actually had to do a little bit of my own research because I've had a huge influx really since the last, let's say 5 years, of babies coming in with feeding issues. So not even, medical babies, just babies, along with babies with oral restrictions coming in. And so where did this all come from? And it really seems to be that there's been an uptick in breastfeeding.
Great.
And so lactation specialists and the doctors from day one, if any babies are having difficulties, they're catching it they're catching it very early because I guess, let's say in the 70s and 80s,
Right.
bottles were the big thing.
And a bottle's easier to drink out of. Right?
Yeah, so for babies, right. So it wasn't noticed as much. Not that breastfeeding ever stopped,
Right.
but I think there must have been I was little then. So
Well, and I think that the lactation consultants are more involved now.
Yes.
Even, my oldest is
educated about it.
16 and my youngest is 12. And even in those years in the hospital, I felt like I had so much support
with the
12 years
12-year-olds.
ago
Yeah.
than I did with my
So
older
I think
son.
that there's been a big change with
Yeah.
that. So with that being said, more kids having difficulty latching. More kids, they're not being exposed to all different, bottles and the breastfeeding. They're just dealing with the breastfeeding more, but they're having a lot more struggle with it, but not sure where they're turned because they don't want to go to bottles.
Right.
A lot of my families, so they'll come to me saying, "But now I'm going back to work." Now they're not moving to bottle. And they're having all of these different struggles because. They just kept doing it, but their child's not moving to the next phase. So they kind of got by. They might have even known about the tongue ties or any kind of like latching issues. They'll use what's called like a shield to just get by and make it work. But then moving to the next phase, they either know that their child has oral ties and now they're struggling at 6 months and up, or they never knew.
Explain what an oral tie is.
So oral ties are where there's a shortening in the tissue in different places in your mouth. So it can be at the front of your tongue, and that's really the most common one that people know about, the tongue tie, where like if you stick out your tongue and it looks like a heart shape, the front of the tongue has a piece of tissue or skin underneath that's tight, and it ends up restricting your ability to move your tongue in your mouth. Then there's two other ones that I've even become very educated in, and I'm seeing them not all the time, but I'm making sure to look. And I try not to diagnose. I try to just show my families, this is the end of my assessment. I always start with my functional part, which I'll talk about, and then I look at the structure at the end of my session. I don't do it the other way. But two other oral ties are the upper lip, where there's a restriction there. The tissue is tight. I call it like a little bit of a web almost. It looks like there's like a little bit of web of skin. And then there's even what we call cheek ties. It's another type of oral tie where it's that same like little web of skin, and it's tiny because these are little guys usually that I'm looking at, but they're tiny. And it's a piece of skin that's literally pulling between the cheek itself and it's attaching to the gum line of where your teeth would be growing in. And I had never seen this, and now I've seen handfuls of them. I've had children though with like red cheeks and struggling with eating and all of that, and then all of a sudden you'll look underneath and it's almost like the blood flow of their skin is just not flowing correctly. They get it released, and all of a sudden, like the blood flow is moving.
Wow.
So it depends on how restrictive, obviously. But so those are oral ties. That's been something not newer in the field. I mean, they've been around forever. It's a congenital. It's a congenital issue. But I think that because more children have been breastfed, it's becoming more evident because more kids maybe are struggling from day one.
So a definite uptick in diagnosis. Also, a lot of professionals are being more educated about it.
Yes.
So if a parent's told that their child has a tongue tie or a lip tie or a cheek tie, what do you recommend?
I don't really have an exact recommendation, to be honest with you. We were talking about function. So I look to see if they come to see me and they already know that their child has this, but they don't want to do anything like a surgical intervention. I'll look at their function. So which means, how are they eating? Are they able to get by on the foods that they're being offered? Also, how old are they? Are they 6 months? Are they 9 months? Are they 2.5? So, but how are they functioning? Are they able to eat everything in front of them? If they are, I may just leave them.
Yeah. And there's no
Who cares,
issue.
right?
Yeah.
But those children, babies or not, that come in and say, my child takes an hour plus to eat. That's not functional.
Right.
My baby's vomiting literally every meal. This is why I don't wear great clothes to work because I get thrown up on. I do. So, but, my child's gagging on everything I try. Purees they're gagging on, crunchies, the dissolvables. And they're 9 months old and I want to move them forward. So that's not functional eating either. So I have to make that decision to say, are they functionally eating? Then just leave them. But, I always try to also be an advocate for their child and say, you know what, when you're ready, get a second opinion. Here's some recommendations.
What type of discipline do you usually?
So I'm feeling a little bit more comfortable lately, more with a dentist, a pediatric dentist, sorry,
Okay.
that specializes often in oral ties. Because I just feel like they can handle the babies. But ENTs also can look and help, and I'll often do that recommendation, especially if kids have hearing issues, anything else going on. They snore. They're stuffy all the time. So I might actually move to that road depending on their medical background. There's also plastic surgeons that do this. So sometimes the families already know who they want to go see. If this is a brand new thing, I'll often say also go talk to your doctor first, your pediatrician, and speak with them and see who they recommend. Because I don't always want it to just stop with me because my background is I'm not a doctor. I've worked with many, many kids with all different kinds of backgrounds, but I always like to know that the medical piece is looked at.
So there is a controversy back and forth about who can diagnose a tongue tie. It's a lot that I read often, and there's the frame of thought that's saying a speech pathologist can diagnose that, which I believe is true, but others are saying it just has to be a doctor. So I love that you will, even though you have your impressions, you'll always recommend and say, you know what, let's get a second opinion and see. It's not, it buck stops here. It's the end all be all because time and time again, we are seeing this happening with families where they'll come from other places. And unfortunately, these therapists may not be as scrupulous as we would like them to be. And they walk in and they say, oh, you're walking on your tiptoes. You have a tongue tie. Go get it clipped. Like, crazy things we're hearing. And I know you come to me in like tears. You're so upset that these families are coming, and these are families that have the wherewithal and know, wait, this doesn't sound right.
And I think that's the biggest point is you need to do your research and always getting a second opinion is worth anything when it comes to your child. When it's
agreed,
especially when it's surgery. And I've seen a lot of discussion in the discussion boards. I guess now it can be done either with a laser or an actual clipping. Do you see a difference in?
Yep. So not that I see a difference at the end.
Right.
But from the start, the laser approach seems to be less invasive.
Yeah.
Babies don't have
So
to
they have to go to sleep? No.
It's like a 2-second procedure. Obviously not 2 second, but it's very quick. And there's no stitches. The other approach is the child goes under and there's actually stitches involved. The stitches, then you don't have to do exercises as much, whereas the more of the laser approach, you have to do for I think it's usually a month's worth of time. I think it's every 4 hours or so. Every doctor does it a little bit differently, but there are exercises that they have to do with their babies.
We're actually getting a lot of referrals too for PT from doctors saying that the kids should actually do PT exercises after the surgery too or before, because a lot of them tend to have torticollis. Because
explain what that is.
Well, torticollis is a head tilt, so the head is, I don't want to say stuck, but it's the muscles get tight, kind of like the tongue tie is a tightening
restrictions.
and there's a restriction of how a baby's turning their head. So they'll always have their head tilted either to the left or to the right. And there is a lot of connection with the tongue tie and the torticollis. So a lot of the doctors are referring the kids to actually get, physical therapy too, to work on their neck muscles and, strengthening their upper shoulders and neck while they're doing the therapy for the tongue as well.
Yeah.
We always say, look at the whole child. It's
Right.
never just making a beeline for their mouth,
Right.
right? We're always looking
Yeah.
at everything.
Well,
So
because our whole
important.
bodies are connected,
Yep.
right?
Yep.
And the tongue muscle is actually a huge muscle.
Yes.
It's not just what we
It's not
see right in the
little.
front.
No,
It goes
connects
all the way
down.
back.
And that's the thing; it goes all the way back and connects, to the spine
Yeah.
and to the neck, where that then becomes tight because of the tightness in the tongue. So,
Yeah.
But just doing body work alone
yeah.
is not the
No,
answer
no.
Yeah.
to a child being able
No.
to manage different foods and
No.
doing all these
And
things.
that's- there's a lot, and like I said, doing your research and figuring out what the real issue is too, because I think.
Thank you. Say that again. You're figuring
looking
out
what the real issue
Yep,
is.
that's huge.
Yes.
Yeah. So assessment, evaluation,
Yes.
it's key. And I'm hearing how thorough your evaluations are and how important it is, because it's not enough to just work on something. You have to know why you're working on it. So
Yeah. And it is
yeah.
important. Like I know Jackie will refer out to PT or OT
Mm-hmm.
if she sees something. Just like I said, OT will refer out to speech if we see something. So I think that multidisciplinary approach is so helpful too when it comes to something like
Always.
feeding or, and working together.
Always.
how, I get this question a lot, how are feeding and speech related, if anything? And I know that we always say the muscles we use to speak are the muscles we use to eat. So how would a tongue tie? We know how it affects feeding. How could a tongue tie affect speech?
So basically in the same way, it's not about safety anymore, but it's about clarity and accuracy in speaking. So if you can't bring your tongue all the way out forward, you may not be able to produce or get full accurate speech sounds if you can't bring your tongue fully forward. Same for bringing your tongue all the way up. We always talk about elevating your tongue to the roof of your mouth for many of our sounds. So a true anterior or front tongue tie is a huge one that we will see speech being extremely impacted. For feeding, what I'm seeing is actually the posterior are even the more difficult cases. The restrictions at the back, and that's where that gagging and choking is coming in. So it's different places in the mouth. But for speech therapy, it's that elevation. We need the tongue to come up to the roof of our mouth to produce many of our sounds. So the minute that the tongue can only go this far,
You're not getting the
and we can only do so much with exercises and strategies and stretching and all of that. It becomes a point where how much can we do functionally versus your anatomy can only do so much. And I don't want to frustrate
I
my
was
kids.
just going to say it frustrates them because we're
Yeah.
asking them to do something that they physically can't do.
Yeah.
So a lot of times we hear parents say, my child has a lisp, and we say, yes, we see the tongue coming forward for the S, but we should not see the tongue coming forward for a T or a D because those are the sounds where the tongues go up. So that's why we would go ahead and look to see if there was any reason why the tongue's going forward and not going up. Yeah.
And that's not usually tongue tie related. That may be actually other medical problems. We talk about adenoid enlargement, tonsils being enlarged. Sometimes if they're snoring, maybe there's even something further back. And it just forces sometimes their mouth to be open.
Right.
It could be low tone and something more of a genetic issue. But and that's why we definitely need to figure out where
What's
it's coming
causing.
from and can we even work to help it.
Right.
And that's these referrals out to doctors.
Yeah.
And I'll always say I can help you this far,
Right.
but definitely, or even an audiologist getting your hearing tested. I can help you, but if we're missing anything, we want to make sure that their child is hearing everything that they need to hear. Not
Right,
that they're
because
hearing or not.
Not only are the parents going to become frustrated when there's no
Right.
progress, but so is the child.
So the medical piece, referring out to all the different doctors, to me, just kind of, again, make sure that we're looking at the whole package and the whole person.
One of the reasons why we started this podcast was Carolyn and I are always talking about how we can get the word out, especially for small ones, about educating parents about assessment and evaluation and how early identification is key. Because what happens, and I have to tell you or tell the parents, if something's not diagnosed early on and then it becomes habitual, it becomes that much harder to undo it, or a child's, especially with feeding, behaviors occur, or like
frustration.
frustration.
They can't speak properly.
Yeah, yeah. So how important it is for assessment. And the worst case scenario, we always say, you come in, we do an assessment, we say, you know what, right now, age appropriate with the normal limits, you're good to go. But let's get that assessment going. So I'm loving seeing much more now families coming in, especially for those feeding concerns. I mean, they're coming in, how old are some of the babies you see?
Majority lately has been like 9 months
Little
to
ones.
15 months.
So I'm so happy to hear
Yeah,
there
that's
has
right when they're
been,
starting to eat.
Yeah, right when
Right.
they're starting to eat.
Yeah.
but seeing that wait and see doesn't work.
No.
Right.
Especially when it comes to the health and safety when you're talking about feeding. The wait and see doesn't work, so I'm so glad we're seeing that the babies are coming in and parents are noticing that, so.
Yeah.
And we're seeing progress too, so
Yeah.
it's been good.
Yeah, Jackie's always getting texts and email. I mean, they're emailing me saying, you know, Harla, thank you so much. Jackie's incredible. She's helped us so much. Or sometimes they'll come in and maybe 2 or 3 sessions. And it's not even that you have to be spending like months and months. Sometimes it's just things that you're tweaking. And just that knowledge, I just think it's priceless.
And the
So,
connection, you know, just making the connection with the families to allow them, you know, to have some support. I think that giving them the support
yeah.
opens up a world for them. They don't feel alone, and they can
Yes.
ask me questions anytime.
Yes, yes. So, I think next podcast, what we have to do is open it up to questions.
Yes.
Ethan, can we do something where
Parent
we do like a lot?
questions?
Yes, I feel like we have to get pet questions because
Yes.
we're asking the questions, but
Yeah.
let's get parents asking the
One
questions.
thing I wanted to ask you, because I think this might be helpful for parents, transitioning to a cup, a sippy cup specifically.
Oh, the sippy.
You know, what is your take on using a sippy cup?
So I usually tell my families to start around 6 months with any kind of cup at that time, just to have something out in front of their child so that it's not just about breastfeeding, not just about bottles, and that it helps with kids being flexible, that there's all different kinds of things in front of them at all times. So that early on, I actually don't really care exactly which cup it needs to
Right.
be. The big push is always straw drinking, just because there's multiple reasons, but it helps with the suck. It helps with tongue placement. It helps with teeth alignment.
Gives great sensory input.
Good sensory input. But so transition, I do in the very early stages. It's just exposure. But 9 into 10 months, I definitely encourage straw drinking. If I have families that come in and their children are 2 years old drinking bottles, at that point too, I'll just say right now I want to move off of bottles. You know, use maybe a sippy, which is always going to be a more of a flexible top, not the hard ones, to transition off. But then all meal times need to be with straws. So by that later time, you know, a year to 2 years plus, it should be everything.
Yeah.
Kids
There's so
get
many
into
cups out there now. I'm sure it's overwhelming
Yes.
for parents.
The biggest one that I have a concern with is this more of a new term, this 360 cup, where it looks like a regular drinking cup, but it's like a whole top on it, and it's actually a concern for me because if you actually sit and drink from it, you're not using the right muscles to just drink from a cup. You're actually sucking and drinking at the same time, and your body doesn't do that naturally. So, because I tried it, and I was like, wait. So then you're taking a child that actually has difficulty with all of these skills, and now you're teaching them the wrong skill.
Jeez, making it worse.
So I'll actually, if parents ask, you know, I'll say, let's put that one to the side for right now, and these are my recommendations. So there's not, to me, there shouldn't, again, just like we're talking about eating, there shouldn't be this exact, you have to do
this
this.
cup or this
Life
time.
can't be that cut and dry. So I try to take my expertise and say this is probably the most successful and maybe the safest, or this will have the least repercussions like dental problems and things like that. But if you have these, let's pick this one from the one that you have. You know, all of these cups are very expensive.
Yes.
So I don't want to be saying, you need to leave here today and go buy those
They come
cups.
in with
But it
like
doesn't
20
work.
cups.
Yeah, it doesn't work. And they're
So
like,
there's
I
a-
just spent
there's a-
$20 on this.
a delicate balance to show what's the best, but also be respectful of my families.
Yeah.
And also help them transition from what they do have in front of them, and then show them the best ways to move. You know, the best thing is definitely straw drinking, but
Yeah.
also and cup drinking, strong cup drinking.
Open cup, like an open cup.
Regular cup, yeah. But we can't always get there right away. So if there's sippies in the middle, life is never so cut and dry.
Yeah.
But I definitely, the hard straws, there's like all these,
Yeah.
you know, big, heavy duty, you know, metal things that these little 2-year-olds are holding.
Like a Stanley.
It's bigger than they are.
Yes, with like the hard square straw. No, and then talk about suck, swallow, breathe, and failure to thrive all at the same time. How do they do it all? So those those and hard sippies, I will say to my families, let's put those totally aside. Because then I get nervous for their teeth too.
Yeah.
Yeah.
And even jaw movement, so
Yeah.
it could have other repercussions.
Okay. Well,
Okay.
I want to thank you,
Yes,
Jackie,
that was
for being
great.
here. So much information. There's always so much more. If you are concerned about your child's feeding, speech, sensory issues, please, get an assessment. You can certainly come to the Speech Tree and Ready, Set, Grow. Jackie's available. But if you're not in the Morganville, Monroe, and Princeton area, please, find someone. It doesn't have to be by us. Just if you have a concern, go ahead, get that evaluation, and just get the answers that you're looking for. Because wait and see,
Doesn't work.
it doesn't work. It doesn't work.
Thank you.
Thank
Yes.
you. Okay. Everyone, have a great weekend. Bye-bye.
Bye.